And thanks to everyone for joining us for the talk today. I hope that I'll be able to give you some updated information for those of you who have already seen my previous talk, as well as answer questions that you might have. So I use Zoom every day in class, and now I did it wrong. All right. Today I'm going to be, again, giving you some updates on details of the coronavirus biology and hopefully addressing some of your questions. And some of this information is based off of information that I've been asked in various formats over the recent days, as well as some questions that have come into a podcast that I co-host recently. And so just to get everyone up to speed, relative to, in case you haven't seen my previous talk, of course, we're talking here a little bit about coronaviruses. I want everyone to remember or learn, if they weren't previously aware, that viruses are a type of biological entity that are called obligate intracellular parasites. And what that means is that viruses need some kind of cell to reproduce. When viruses are outside of cells, they really aren't doing much of anything. It's only when viruses get into cells that they are able to reproduce. The virus that we're going to be spending a lot of time talking about today, and that you're probably hearing a lot about in the news right now, is a member of a family called Coronaviridae. It was so named because when you look at particles of the virus under a microscope, scientists thought it looked like a crown. And so corona is used because of its relationship to the word crown. This virus has a positive sense single-stranded RNA genome. So what that means is that inside of the virus, and you can see a cartoon image of the virus in the lower left-hand corner, you can see that inside there's this black squiggly line, and that is the virus's RNA. That has all the instructions for how to make new viruses when the virus is reproducing. And it's single-stranded, and it's what's known as positive sense RNA. And importantly, the outside of the virus is made out of a layer of lipids, which makes this virus what's known as an enveloped virus. And those lipids are actually a pretty important part in how we try to disinfect surfaces and remove viruses from our hands. And that's why I specifically mentioned those lipids. The virus that you have been hearing a lot about lately is not the only coronavirus in existence. There are a whole bunch of coronaviruses out there. 6 others infect humans. 4 of them are pretty regular human coronaviruses. They cause 30% of all colds, and they've been replicating in humans for a while. There are also 2 other coronaviruses, SARS-CoV, which causes the disease SARS, or severe acute respiratory syndrome, and MERS-CoV, which causes the disease MERS, Middle East Respiratory Syndrome, are 2 newer coronaviruses that emerged in the human population in 2002 and 2012 to lead to some pretty severe outbreaks. The virus that everybody's talking about in the news right now is officially called SARS-CoV-2. SARS coronavirus 2, and it got that name because it is so closely related to the previous SARS coronavirus, which I've heard a few virologists refer to as SARS Classic recently. And what you've more likely heard is a term called COVID-19. COVID-19 was the name that was given to the disease that is caused by this virus. It stands for coronavirus infectious disease that started in 2019. And it just so happened that both of these names, the name of the virus and the name of the disease, were announced on the same day. And so most people ended up hearing about COVID-19 and missing SARS-CoV-2. It's okay if you missed out on that. This infectious disease, COVID-19, has some symptoms that we see in a lot of patients. They include a fever, so having a pretty high temperature, a cough, and having some breathing difficulties. And this infection was first detected in a group of patients from China who had atypical pneumonia. As we look more at some of the people who seem to have this infection, it looks like the majority of them have very mild symptoms. Now, when I say mild symptoms, I mean symptoms that might resemble symptoms you'd see with the flu. Symptoms where you could stay home in bed and take care of yourself with some home remedies and things like that. You're not going to need to be hospitalized. I heard a report earlier today from a colleague who was infected, and this is a famous virologist who studies a lot of different viral infections, and his exact words for how he felt with his mild symptoms were that he felt rugged. So these aren't, totally mild, you're going to be completely fine symptoms, but these are symptoms that don't require hospitalization. About 13.8% of those who are infected seem to have severe symptoms that require them to be hospitalized. And the remaining individuals, about 4.7%, need some type of intensive care. You might look at these symptoms and think about then how this virus is moved or transmitted from person to person. And if you look at the image on the left, you can sort of get an idea that this viral infection has something to do with the respiratory system. And as a result, it also is spread through the respiratory system by something called respiratory droplets. And so when an infected person coughs or sneezes, they will have respiratory droplets that contain the virus that are coming out, as you can see here. What you should notice is that there are droplets of varied sizes that are being produced by this person. Some of the larger droplets are going to be pretty heavy, and they're going to fall out of the air pretty quickly. Others will be a little bit more dry. If we're using technical terms, they're called droplet nuclei. And they can actually travel for longer distances in the air. One thing that is a little bit scary when you think about it is that sometimes people wonder, well, how exactly or when exactly does a person who is infected make these respiratory droplets? We do see a lot of those respiratory droplets when people are coughing or sneezing, but something that will be important as we go forward is that there are some respiratory droplets being made right now when I'm talking. There is a really cool paper where someone actually had people talking with dye in their mouth and got to see how far the dye went. There even have been studies for other respiratory viruses that showed how much was actually in droplets that came out just from breathing. And so different activities that involve your respiratory system will allow for different amounts of transmission. There might be more or less droplets. Those droplets might have more or less, say, force behind them if they're not coming with a sneeze. But there are going to be droplets being made all the time. And those droplets are going to allow for transmission from one person to the next. the big, heavy, wet droplets are going to fall out of the air pretty quickly. But the smaller ones are going to be able to float longer in the air, potentially going from one person to the next, or potentially landing on surfaces. When scientists did a study, that study was recently published in the New England Journal of Medicine. I'm using a table that was made by one of my colleagues because I think it looks prettier, but you can find all of these data in the New England Journal of Medicine. These investigators saw that this virus could be detected up to 3 hours in the air. And so that kind of gives you an idea of how long some of these droplets that may contain the virus are spreading throughout the air. You can see that the virus can be stable on some types of surfaces like paper or cardboard or steel or plastic for different amounts of time. I'm sorry, that's copper. I have my chat window right on top of copper. And you can see that the virus lives for a rather short amount of time on copper. It's actually a really interesting thing that a lot of people are studying. That's true of a lot of viruses and bacteria, and we don't know why. And you can see that it can live for about a day on cardboard, a little longer on some other types of surfaces. But thinking about these surfaces in another way is also a little bit important, because one of the other surfaces that we need to care a bit about is the surface that is your skin. Your skin, as far as viruses are concerned, actually sort of counts as a surface because the top layer of your skin is made out of dead cells. And I told you at the very beginning that viruses are obligate intracellular parasites. They need to get into a cell in order to reproduce. And so if they land on a dead cell, or if they land on a plastic table or something like that, there are no cells. Those viruses can't reproduce. The trick is that the viruses would like to be able to get to some kind of mucosal surface, like your eyes, or your nose, or your mouth, or your GI tract, where there are some live cells in a nice wet environment where those viruses are going to be able to reproduce. So having the virus on your skin isn't a big problem. The thing that could be more problematic is if you have that virus on your skin and you were to touch one of those mucosal surfaces, sort of give the virus a ride into your eyes or nose or mouth. And you could, of course, have it on your skin, give it a ride onto one of those places. You could also, touch a surface like the plastic table and move that virus into the mucosal surface. This leads to a couple of different types of questions I've been hearing a lot from some people. So some people have wondered about whether they should interact with others in certain stores across a plexiglass barrier. That may work to reduce the amount of virus that is coming into an individual, but it sort of depends on how big the barrier is and how much air is going around the barrier and exactly what the parameters are in that situation. Others have wondered about whether or not wearing glasses will afford them any protection, because glasses will, of course, protect their eyes. I think that glasses will give you a little bit of protection, but again, remember that when you're wearing glasses, there's space to the side of your eyes, space above your eyes, space below your eyes, where air can get in and where you might be touching your eyes pretty frequently. When you have glasses, you touch your eyes a lot, you push the glasses up on your nose. And all of those things could be situations where you could take the virus from a surface like your skin into your mucous membranes. When researchers are or when physicians are trying to have full precautions against droplets, they do wear goggles to protect their eyes. And so eye protection is important here, but we have to remember that there are going to be some ways that things can get to your mucosal surfaces around those glasses. Some people have wondered about hand washing. The fact that your skin is basically a surface on which a virus is going to be able to land is one of the reasons why we want to be washing our hands so often to get any viruses off. And so when we've touched different things that we think might potentially have virus on them, hand washing is great. Other people have asked, well, if the problem is touching your face, then shouldn't you be washing your face all the time? Realize that if I were to touch some other part of my face, like my cheek, the virus wouldn't have some way to get from there into my mouth or some other sort of way across into a mucous membrane. And so it's really the way that you're going to get the virus into the mucous membrane is by moving it with your hands. That is kind of the most likely way that we're going to see that virus transmission. So based on what you've heard from me thus far, you might think, wow, this sounds a lot like the flu. It's a respiratory virus. It causes some respiratory symptoms. It's transmitted by coughing and sneezing and other respiratory droplets. But there are a few key differences between infection with this virus, SARS-CoV-2, and infection with the influenza virus or other types of respiratory infections that might cause the common cold. And so if you're feeling worried about whether you might have this particular viral infection, note that with this virus, you tend to have a fever very commonly, and you rather commonly have a dry cough. You also may have some things like aches and pains or shortness of breath. And there have been some reports recently about loss of taste and loss of sense of smell briefly. It's not clear if those are going to be super specific to this viral infection or whether they are specific to other types of respiratory infections. If you look at all of the infectious diseases we tend to see on a yearly basis, we see far more colds than any of the other major respiratory infections. And so if you're around somebody who is coughing, you don't necessarily need to run away from them in terror. It's entirely possible that they have a cold. And most likely, if you're feeling sick, you may end up talking to someone at a healthcare provider, and they're going to ask you some questions to see whether your symptoms match up closely with the coronavirus symptoms versus cold and flu. And those are all pretty easily distinguishable based on some symptoms. But there are some other things that distinguish the coronavirus from the flu as well. And so at the top, you can see little cartoon images of the influenza virus and SARS-CoV-2, as well as two other coronaviruses, SARS coronavirus and MERS coronavirus. And to me, as a person who thinks about viruses a lot, I can tell you that those cartoons are sort of accurate depictions. And to me, I would think, how could anyone confuse influenza and SARS-CoV-2? They look so very different. So I don't know if those of you who are not looking at viruses as often will see them as crazy different in the way that I do. But there are a few other things that end up being really different about these. One thing that you can see here is there's a big difference in the rate of people who are hospitalized. So with flu, only about 2% of those people who are infected end up needing to be hospitalized. While with COVID-19, this new coronavirus, almost 20% of people end up needing to be hospitalized. And so that's a big difference. And it's a really big difference if you think about all of our doctors and nurses and healthcare providers and sort of the work that they're going to be asked to do to take care of those patients. If you think about the hospital beds, if you think about all of the hospital supplies and things like that. When most flu patients are able to be at home and not be hospitalized, whereas significantly more of these patients are going to be hospitalized, that makes a really big difference. There also are differences in what's known as the case fatality rate, or CFR. And so with flu, the fatality rate is thought to be between 0.5 to 0.1%, or 0.05 to 0.1%. Those are definitely estimates. With SARS-CoV-2, an estimate, and this is very much an estimate, of the fatality rate is that it's about 3.4%. That fatality rate involves knowing how many people are infected, and we aren't really sure about that right now with SARS coronavirus 2. So that's why this is such an estimate. But you can see that this is a big difference, that this virus is causing significantly more deaths than we see with the normal influenza virus. On the good side, this virus causes far less fatality than the original SARS coronavirus or than MERS coronavirus, but it's still a lot more than the flu. The other things that are really sort of unique about this virus are the incubation time. I'm going to talk a little bit more about the incubation time in a second, but you can see here that it's listed as between 4 and 14 days. And the final thing that's really sort of unique about this virus is something known as its basic reproductive number, which is the number of people or the number of cases that an infected person will lead to. So each infected person will infect about 2 or 2.5 others on average. And so this is sort of a question of how contagious this virus is. And so if you look in comparison with influenza, this virus is more contagious than influenza. So we have a virus that is more contagious than influenza, that leads to more deaths and that leads to more hospitalizations. This is something that we really need to be aware of, and potentially we really need to be worrying about. I've also been asked about the difference between something being infectious and something being contagious. A contagious virus is spread from person to person. So here you can see a person and a person, and the virus being spread between them. Something that is infectious is something that you can acquire in terms of a bacteria or a virus that gives you the infection, but you don't have to get it from another person. So an example of that might be something like Lyme disease. You don't usually get an infection with Lyme disease from another person. You usually get it from a bite of a tick. And so that is infectious, but not contagious. Something that is spread from person to person is both infectious and contagious. So as a result of all of these numbers that I've shown you, that leads to this case fatality rate that's somewhere in the 2 to 3% range. And you will absolutely see different numbers there because of the fact that we are still estimating what's going on here and don't know how many people are infected. Most of those people who have serious disease have some other medical condition like hypertension or diabetes, cardiovascular disease, or something like that. And in the figure on the left, you can see a breakdown in different age groups. And the blue striped bars show you the number of the percent of the cases that were in that age group. And so you can see that there are cases in people of many different age groups. There are cases in the 0 to 9 age group, all the way up through the above 80 age group. In the red bars, you can see the percent of those that are fatal. And you can see that there really are very few fatalities in the younger age groups. But there are significantly more fatalities when we get into the higher age groups. And some people have used this sort of information to have you think that perhaps only those individuals who are in the higher age groups should be staying away from others. Maybe we shouldn't worry so much about spread with the younger age groups. But one of the things that has honestly been the most striking to me as I have learned about this virus has to do with something with what it's known as its incubation rate and its ability to do asymptomatic spread. I'm using an image from a paper that was published here. There are a couple of things about the data in this paper that are not perfect, but I chose to use this because it was a nice picture. And the other ways that I could talk about this really were not as visual for you. And so if you have heard more about this story, yes, I am well aware of some of the issues with this story, but I wanted to show the visual in order to make a particular point. And so what you should notice here are that there are 5 different people, each represented by a different color. One of those people went on a visit to Germany and attended some business meetings and then flew back to her home in China. You can see that she had symptoms according to this chart on January 22nd, and she tested positive on January 26th. She was in business meetings with person number 1 on January 20th and 21st in the sort of darker yellow. In business meetings with the green person in 21 and 22. And she came into contact with person 3 and person 4 on the days listed with the C. So you can see all of the days when, in theory, these people could have caught this virus from the original patient. What I want you to first notice is that the days where these people caught the virus from this original patient were before this patient had symptoms. And so this patient didn't know that she was infected when this was happening. She couldn't say, oh, I should have stayed home at that point. She didn't know she was sick until she had symptoms. And what you will also notice is that in many of these patients, between the time where they potentially caught the virus and between the time where they had symptoms, there was a fair amount of time. This is known as the incubation period. And we now know that it seems like people can transmit the virus during that time. And so we can't just think about isolating people who are sick with this virus because or isolating people who test positive. With each of these individuals, you can see an arrow where they tested positive, and you can see that there's a big difference there between when they perhaps acquired the virus, when they had symptoms, and when they tested positive. I've never seen something like this before with a virus and its ability to spread like this, especially to this degree asymptomatically. And so some of the typical things we do with epidemiology in order to stop the spread of different infections, like a lot of contact tracing, can become really challenging when there are people who are spreading with no symptoms. It makes it really hard to be able to track down all of the people who are infected and all of the chains of transmission from one to another. It also makes it really hard to isolate the people who might be spreading this virus because so many of them will feel perfectly fine and have no symptoms. We think that it's possible that this may have to do with the fact that this virus is pretty sneaky. This virus actually is unique from a lot of other viruses in that it can replicate both in the upper respiratory tract, which is really good for spreading, and in the lower respiratory tract, which is really good for causing disease. Most respiratory viruses can only replicate in one or the other place, but this one has the ability to replicate in both. And so that may be why it can spread from the upper respiratory tract early and then later go down into the lower respiratory tract and start to lead to some symptoms. And so all of these things make me realize that this virus is very different than a typical flu infection and is something that we really need to think about very differently than some other outbreaks that we've seen. This virus has led to 441,187 cases. This is the Johns Hopkins University site that reports on data. When you look at the data coming from different sources, there are multiple stages of reporting that tend to happen. And so sometimes you will see differences between the numbers because, for example, one site cuts off at noon in New York every day for its new data, while another site might cut off at 4 p.m. Another site might get data directly from the state labs, while further others might actually wait until there's been confirmation from the Centers for Disease Control. You also have to look at things like, are we measuring cases or are we measuring deaths? Are we measuring number overall? Are we measuring the number per million or per number of residents? But you can see that this is not a virus that has been very quiet. It has been causing huge numbers of infections all around the world. And you can see foci of infection on this map. It's led to almost 20,000 deaths at this point, but happily, it's also led to about 112,000 people recovering. There are some other sites that will allow you to get some really nice data. So there is this site called Worldometers. So most people who are in infectious disease get a lot of their news from this particular news source called ProMed. ProMed has actually switched to using Worldometers now because they think it is more up-to-date time-wise than the Johns Hopkins site. The nice thing about this is it actually shows you both numbers of cases and numbers of deaths, as well as being able to break those cases down into things like cases that are serious versus the rest. And so that might help you understand things like hospital capacity and the need for ICUs, as well as things like cases per million or deaths per million. So you can take into account the size of the population of the country that you're looking at. And so you can see the dramatic differences in some of these numbers. Some people like to look at number of cases to understand what's going on with this epidemic, but we should always realize that looking at number of cases is difficult because it is reliant on whether or not we are doing testing and also how many people are getting tested. There are some areas of Italy right now where they only test people who are really sick and tell everyone else to go home and try to get over things at home. And so that's going to influence some of the data that we're seeing. With a lot of people think that looking at deaths may give us a better idea of what's going on, but realize that the deaths are partly related to whether or not a particular area has a good healthcare system. And so there are variables to be thinking about with any of these measures. Here you can see the data on COVID-19 cases in the United States. New York State seems to have the largest number of cases at this point, with New Jersey coming in second. But places like Atlanta and New Orleans and Florida are having some rather rapidly emerging epidemics. And so there are really no parts of the United States that seem to be unaffected by this virus. You can also see information on the number of cases in the United States here shown in a different way. And this shows you the number of cases in the United States based on the day that that person actually reported their case, based on when that person officially got diagnosed, officially got a positive test. And you can see that we are still very much in a phase where we are increasing in our number of these cases. But what you should also note is that these data can be thought about in a slightly different way. Here you can see those same cases now graphed based on when the patient started to feel sick. There's a little bit of time between when the person feels sick and when the person goes to the doctor, when the person gets a test, when the person gets their test result. And so what you should really note here is that there's this big part at the end where it says illnesses that began during this period may not be reported. The thing that's important to realize about that is that people who are testing positive now, people who may have been testing positive at this peak at the end here on March 24th, yesterday, probably correspond to these people who felt really sick in this peak about March 14th. And so anything that we do now in terms of changes to our behavior are probably not going to be seen for at least 2 weeks. And because the people who are getting sick now are the people who got sick 2 weeks ago. And so we should expect that numbers are probably going to continue increasing right now. And right now, of course, that's why we need to be working on social distancing, because we want to actually reduce the number of cases so that there are enough hospital beds and masks and all of those important things. And so that our healthcare workers are able to take care of all of the patients with this infection, but also with other medical conditions who might need medical care. This is a scary time for a lot of healthcare workers because so many of them know that they are going to be seeing a lot of patients with this infection, and they may very well get sick. And so many of them may have to take a few days off. And so we don't want to have this overwhelming number of people who need healthcare, hospital beds, ventilators, but also the time of our hardworking doctors and nurses. And so if we are able to spread out cases over a smaller period of time because of our ability to do things like social distancing, we're going to help people do a lot better. Just to show you how that works, I really love this image. Here you can see an infectious disease spreading over time. But if a few people pull themselves out of that chain of infection, then the overall number of people who are infected, you can see that huge number at the right-hand side of this, will decrease pretty dramatically. That's what we're trying to do here, is because of this dramatic asymptomatic spread of this virus, we want to make sure that we can stop the spread to huge numbers of people, especially to our friends and neighbors who may be particularly susceptible. And so you can see that in another way here. In the beginning, we might have a couple of people who are infected, and that infection may spread among individuals. The good news is that some of those people will become immune. Unfortunately, the bad news is that some of those people may not survive infection. If some people isolate themselves, whether they're sick or whether they're healthy, that will actually stop spread through the population, and that will keep far more people healthy in the end than we might have seen otherwise. One of the other questions that a lot of people have been asking lately has to do with details of testing for this virus. I've mentioned, of course, that we don't know all of the numbers of people who are infected, and so you might wonder whether testing can be a big part of this. There is a way to test for this virus right now. The test actually looks at that RNA that's inside of the virus and looks to see if it is present in a person. And that will allow us to know whether that person is currently infected. One piece of great news in the scientific community is over the past week, a few different groups have announced that they have successfully generated a different type of test. Instead of measuring the genome in the virus, this other type of test measures antibodies that might bind to the virus in a person who has been infected. These tests are able to be done very rapidly and cheaply, and they measure whether or not a person has been infected, not whether the person is currently infected. And so they may allow us to eventually find out whether or not we have ever been infected and are now protected. And so, like I said, those are scientifically generated tests within the past week, and we're hoping that they should be available sort of for actual use in the very near future. The other big question that a lot of people have been asking has to do with treatments and vaccines that are out there. And of course, there's one treatment that's been getting a lot of information or a lot of press right now, which is treatment with something known as hydroxychloroquine. These data are some of the data from the paper. talking about what happened with patients who were given hydroxychloroquine. And so here we are looking at the amount of virus in the different patients. In red, you can see the virus in the patients who were treated with this drug, hydroxychloroquine. In black, you can see the amount of virus in patients who were not treated. And so you can see it looks like the people who were treated with this drug had less virus. That's a good thing. These data are not great on a statistically. I did notice that we had a couple of Drew's statistics professors who were on the list of people who were listening to the talk. And so I am not going to try to explain all of that because I don't feel like being roasted by my colleagues. But there are some questions about that. And so these data might make one think that there should be more study of hydroxychloroquine, but they certainly don't prove that this is some sort of miracle. This is a drug that is currently used in patients who have malaria, as well as patients with autoimmune diseases like lupus and a few others. And it has some decent side effects, particularly cardiovascular side effects. This is not something that everybody should be taking. And right now, patients who need this drug are having shortages. And there are some people who are doing things like seeing words on other products that sound similar to hydroxychloroquine and taking those things and having them be dangerous. So that is not ideal. But there's one other thing that I would caution you about before thinking about hydroxychloroquine as some sort of wonder drug. So this represents what happened in that study. There were 16 people who were in the control group, and there were 26 people who got the hydroxychloroquine. I'm oversimplifying some things a little bit here. In the control group, out of those 16 people, 12 of them had some symptoms and 4 had absolutely no symptoms. In the hydroxychloroquine group, there were 2 people who had absolutely no symptoms, and there were some others who are shown here in green who had symptoms. But that's not the whole story. There's this other group of 6 people in that hydroxychloroquine study that are shown at the bottom. It turns out that the researchers actually took 6 people out. They threw them out of the study. In reality, it's because these people didn't finish the study. The reasons why they didn't finish the study were that 3 of them went into the ICU. One of them had really bad nausea from potentially that treatment, and one of them died. And so if I actually look at all of the people and what happened to them, how they felt between these 2 groups, I don't know if the hydroxychloroquine group is the group I want to be in. It is very true that that drug reduced the amount of virus in people who took it, but it's not clear that that had a big change in how those people actually felt in terms of their symptoms. This is enough evidence that there are going to be some more clinical trials, but this is not a drug that's sort of ready for prime time yet. And so yes, there are some clinical trials. There are some other medications that seem to have additional promise. There's a drug that was already shown to work against other coronaviruses that is in multiple different clinical trials right now called remdesivir. The FDA today approved the use of antibodies from people who had recovered. So people who had recovered from coronavirus infection can donate blood. Antibodies can be purified from that blood, and then those antibodies can be given to people who are very sick in order to treat them. Like I said, the FDA approved that use of convalescent serum today. And there are clinical trials being done of vaccines. One that a lot of people are really excited about uses RNA and is being done by a company called Moderna. All of those things are promising, and hopefully within perhaps a year, we may have some great news on this front. Right now, the best thing we have is the ability to protect ourselves and our neighbors by doing things like giving Zoom talks from our dining room. Thank you all for coming, and thank you all for your attention, and I'm happy to answer your questions.
Thank you so much, Professor. So we do have a couple questions here, and some are starting to flood in. So I'll start off with a couple here that we have ready. The first one being WHO, CDC, and government websites all post the number of cases, but where can we get and find the number of serious cases, ICU, incubated, and recovered cases? Aren't those numbers more relevant to the crisis at hand in terms of healthcare system overload?
So that's a really great question. So right now, Worldometer is actually the best place to get numbers like serious cases versus non-serious cases, but there are no places that I currently know of that are doing things like ICU numbers or numbers of people intubated. And I think that the reason for that is that is changing very rapidly in our hospitals in terms of what's happening with those patients. And right now, the need is for healthcare workers to be taking care of the patients and not necessarily giving out all of those numbers. But you can find things like serious cases versus non-serious cases from Worldometer. That's why so many infectious disease professionals have actually switched to using data from that site.
Thank you. Next question is contact tracing occurring at any level in the US that you know of?
There is some contact tracing being done by some public health departments. However, in many cases, people are seeing situations where they are unable to determine an original source of infection because of all of that asymptomatic spread. And so in many of the situations where contact tracing is happening, there are a lot of question marks because of asymptomatic spread. And since this virus seems to have so much of that, it's a real new thing that we're working on.
Next quick question. Who among the population should be wearing masks?
That's a really good question. So most of the data on masks show that masks are really good at stopping the very big droplets from leaving an infected person, but they're not great at actually stopping a person from getting infection. There's a little bit of inconsistency in that data, but it doesn't look like masks do a ton to prevent infection. And one of the things that happens with masks is that they're kind of annoying to wear. And so people end up having to adjust them pretty frequently. Some of the best masks, the high level masks actually have to be fit tested, which most people are really not doing. And so right now, we want to make sure that we prioritize masks for all of our healthcare workers who need them. Because if you imagine a healthcare worker going in to treat some of these patients without a mask, that's pretty terrifying to imagine. And so right now, they should first sort of be, going to a lot of healthcare workers. After that, it's probably a bigger thing for someone who is infected to be wearing one, who knows that they are giving out different respiratory droplets, as opposed to members of the general public who just wear them otherwise.
And I think this is kind of a bit of a two-parter, but what is the most popular mucosal surface for viruses to get into? And I think something a lot of people are worried about in this vein is, what are the precautions we should be taking when we're going to places like a grocery store, out in public as much as we're allowed to?
Right. So, the most common mucosal surfaces would be the nose or mouth. They both sort of feed into kind of the same place. And so it's sort of hard to really differentiate sometimes where the virus is coming in. The biggest precautions you want to take is that you'll want to take will be making sure that you're keeping distance between other people, so that there's a long way that those respiratory droplets would have to travel, and being really aware of what you're touching and when you're touching your face. So one thing that sort of I notice sometimes that I shake my head about a little bit is that when I'm in the lab and I'm wearing gloves, one of the reasons I'm wearing gloves is because I don't particularly want to get some of the microbes that I'm working with. And so I will work with the microbes with my gloves, make sure I'm paying attention to what's on my gloves, And then I take the gloves off and wash my hands before I touch my face or before I eat or before I do things like that. And so thinking about if you were wearing gloves, for example, what types of things you're touching with them, and then taking the gloves off and washing your hands is really important, instead of, say, going around your whole life wearing gloves or something like that. And so I think washing your hands and keeping distance are the most important things for people.
Let's see, what's next? What is the false positive rate of the testing that you know of?
Right now, the false positive rate has not been something that people are seeing a whole lot of. I don't know the number off the top of my head, but I am not hearing about very high numbers of false positives. I am hearing much more about false negatives than about false positives. And so I would say there are very few false positives. There are false negatives. And I don't know if any of you have seen or heard about this, but the way that you are tested is actually you need to get a swab, a nasopharyngeal swab. They have a very, very long swab that needs to actually go into your sinuses. When talking to someone who has had this done, they say that it goes up your nose and kind of feels like they're swabbing your brain. And so oftentimes there will be swabs that are not going in far enough, and that can lead to false negative results, but I haven't heard a lot about false positives.
You spoke about the variation when people test positive after exposure. Is there any info about how long people continue to test positive after the symptoms have subsided?
I haven't seen great data about that. I don't know that there are many people at this point who have been tested more than once. And so you would need to be tested multiple times to really answer that question. And I'm not sure we're at the point where we have enough tests to be doing that.
Okay, next question. Is there any validity to the talk about different blood types being able to clear the virus more or less easily?
So there is a study that has been posted online about different blood types. So one thing to know is that when scientific studies are published, they undergo this process known as peer review, where other scientists read about them and make comments on their validity and things like that. A few years ago, that process of peer review takes time. And a few years ago, there became this movement for some scientists to put their papers on the internet before they'd gone through peer review. And that was actually really important. This happened during Zika because we wanted people to know what was going on with Zika before this whole slow process of peer review. But that's also happening with some of these studies that are coming out, that they are making their way into the internet, and then the media is picking them up before peer review. That blood type study is such a study. It had about 2,000 people in it, and the most striking data were that 38% of people with the virus had type A blood, while only 31% of people who were not infected had type A blood, and 25% of people with the virus had type O, whereas normally 34% had type O. We already know that there are some biological differences here. I wouldn't take those data too terribly far. I wouldn't, be too, for example, excited about the difference between my risk is only down to 25% to 25% or something like that. This is not an absolute at all. So the study right now looks like it's been done in an okay way, but it has not yet gone through peer review, and the data are not very dramatic in terms of the amount of protection.
Okay, next question. If this virus originated in an animal market in China, where would that infected animal have gotten it? And is there any chance that it is a man-made?
Okay. Right now, there are tons of viruses that are infecting all sorts of animals. And so that animal would have gotten the virus from other animals, and that virus may have been circulating in other animals. one of the types of animals that people talk about a lot with all of this are bats. Bats seem to have some pretty interesting relationships with viruses and with immune responses. And if you wanted me to geek out here for quite a couple hours, I could tell you how cool the relationship between bats and viruses is. And so it's very likely that it was in a bat, actually causing no symptoms in a bat, just going from bat to bat for a long period of time. In fact, people have found viruses that look almost identical to this virus in bats for quite a while. There have been a lot of questions about whether, or there have been questions, I don't know if there are a lot, about whether or not this virus was man-made. Many very prominent virologists that I know have looked very, 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 very carefully at the virus's sequence. And there is no evidence that this virus is man-made. I know that there are a couple of stories out there where people say, oh, it has similarities to this virus, or oh, it has similarities to that virus. But I'd have to tell you that most of those things are things like saying that my writing has similarity to Shakespeare because we both use the word the. And so this really, through everything that I have seen of this virus, looks like a very much a natural virus that has been circulating in bats for a while.
Thank you. Do you know why SARS-CoV-2 or SARS-CoV and MERS-CoV didn't spread and infect as many people as SARS-CoV-2? Is there something at the molecular level that can explain the higher transmission rate of CoV-2?
That is something that lots and lots and lots of scientists are looking at right now. It looks like SARS-CoV-2 can bind to human cells a little bit better than SARS-CoV-1. And so I think that that seems to be a big part of the difference in transmission. But I will also say that there were some pretty big preventative measures that were put in place with SARS-CoV-1. And there wasn't the same level of asymptomatic spread. So contact tracing was a little bit simpler. MERS-CoV-2 doesn't spread very well from person to person. It mostly only spreads from animals to people. And so that's a little bit easier to control. But there are a whole lot of researchers around the world right now trying to answer that exact question.
And how do you think COVID-19 will reshape the way epidemiologists will test and prepare for respiratory diseases going forward?
That's a tough one. Sort of hard to really predict a lot of details of the future. I hope that this will re-highlight sort of the importance of training in basic epidemiology. And I hope that this will highlight the importance of kind of thinking about health broadly, thinking about social distancing and stopping all respiratory viruses, be they flu or coronaviruses or other things really broadly, and thinking about being prepared broadly. We had spent a fair amount of time thinking about what would happen with the next big flu epidemic. There was always sort of this idea that the flu was coming. And this is showing us that maybe we were being a little bit narrow-minded and we should have been thinking more broadly about all respiratory viruses. And so I hope that that is one thing that changes this whole thing in the future.
And do you know if epidemiologists are looking and researching into what the next potential COVID-19 is?
There are lots and lots and lots of scientists, whether they are epidemiologists, whether they are virologists, whether they are scientists in a number of fields that have been trying to look for viruses in animals that seem to be able to maybe spread in humans well, that maybe have that ability to bind to human cells really well. And so there are some programs that are trying to find some of those viruses in advance. There are also lots of modeling programs where people are trying to figure out how to predict this in a quantitative way. They often look for disease X or try to model disease X, and now I guess we know what disease X is.
And do you know, or do you think it's possible that the coronavirus is something that's been seen before in the past and may have been ignored as an uninteresting or non-dangerous virus? And do you think this particular one will raise attention for more studies to be performed in animals?
Sure. So there are already 4 human coronaviruses that circulate in people and cause about 30% of colds in people. And I think that there may, and like I said, there were 2 others that have in 2002 and 2012 led to big outbreaks. It's entirely possible that there was also another one in 2006 that we didn't notice. And we didn't really know anything about. And so it's entirely possible that there could have been other coronaviruses that made their way into the human population that we missed. They probably weren't this exact virus, but it's entirely likely that there were some that have been in the population that we haven't seen before. And I think it's certainly good evidence that we need to be looking more closely at viruses in this family.
And now we have a couple more that are just kind of the general practical everyday
Okay.
living sort of things. Once you have the virus, are you immune to getting it again? And how long does the virus stay on skin or other surfaces?
So the specifics in terms of type of surface vary in terms of what type of surface it is. So things like plastic, it can stay up to 72 hours. Things like cardboard, it's about a day. Things like copper, it's about 4 hours. Skin, it's again going to be in a range of probably on the longer side in the number of hours. Skin is really, really good at sticking to viruses. Viruses love to stick to skin. And so I would say, particularly if the virus is in any mucus, it's really good at sticking to skin. I would say it stays on your skin until you wash it. And so the numbers there are things that I can't necessarily estimate for you. Right now, it looks like people do have immunity after they've been infected. That's why we can take antibodies from infected people or from survivors and give them to others. And it looks like you will have durable antibody for about a year. But of course, since we've only known about this virus for about 3 months, we really can't say a lot about that long term quite yet.
And can you briefly explain what herd immunity is?
I talk about herd immunity in class and love to talk about it, so sure. So the idea with herd immunity is that has to do with the spread of some type of contagious virus from person to person among a population. Herd immunity is sometimes also called population immunity. And the idea is that a certain that people are protected when virus transmission stops in a population. So if some number of people are immune to a particular pathogen, then spread won't be able to happen because the pathogen won't be able to go from susceptible to susceptible to susceptible to susceptible person. It'll get blocked because somebody was immune. And so in the future, herd immunity may help to protect us from COVID-19, and herd immunity may partially protect us from many different infectious viruses. Right now, we have 0 herd immunity with this particular virus, and so that's part of why we're seeing such explosive spread. And the specific percent of people who need to be immune for herd immunity to work varies and depends on a whole bunch of other mathematical parameters related to the microbe.
And do you know why the current death rate appears to be so much lower in countries like the USA, Germany, Switzerland, than in China and Italy?
So I think that there are a lot of things going on there. So one of the details has to do with how many people are getting tested and how many people, and so are the serious cases only the ones who are getting tested, or are some of the non-serious cases being tested? The death rate is the number of people who die divided by the number who are infected. And so if you only test the sick people, then you're going to have a pretty small number who are infected, and it's going to look like a huge death rate. If you test a ton of people, you find all your asymptomatic cases, it's going to look like there's a smaller death rate. And so that's part of the reason. The other part of the reason has to do with how well different healthcare systems are able to take care of all their patients, what kind of availability there is for healthcare, or whether the healthcare systems are overwhelmed.
And do most people who show symptoms have those symptoms progress in a similar order, or is it okay? Or
No, not at all. I mentioned before, I am part of a podcast called This Week in Virology, where we have been talking about this actually since January. Last Friday, we recorded an episode where we had an infectious disease physician from Colombia who was our guest, and he talked about some of the patients that he had seen, and he actually was remarking on how much variation he was seeing, and how some of his patients, for example, the first symptom was diarrhea, which wasn't even on the list of the main symptoms you think of. And so the order is very different from patient to patient.
And then we just have one last question here. How do people recover if they have semi-severe or severe symptoms?
So at this point, those who have good medical care seem to recover pretty fully, and have a pretty good course, and not have a lot of complications after recovery. But again, we don't have more than a couple of months of observations there. And so it's hard to know if there's going to be some sort of long-term thing. But right now it looks like they're okay.
Okay, thank you, Professor, and thanks everyone who tuned in. That's all the time we have for questions, but I'll now turn on the Zoom chat onto the public setting if anyone wants to leave any feedback or commentary before I close the meeting in a couple of minutes. Thank you so much, Professor.
Thank you very much. And thanks everyone for listening. I heard from one of the stats faculty that she won't be roasting me, so that's pretty good.
We can consider it a success.
Excellent. It looks like someone is asking about whether there's a link for replay.
Yes, there will be. We will be posting this on Drew's YouTube channel. Usually Zoom takes a couple hours to send us the full file. And so tomorrow morning, I'll be putting it up on YouTube and sharing it on our social media pages, as well as Drew's website. So it will be up within 24, probably even 12 hours to watch again in full. And I just saw the same question again, so I'll just reiterate before I end the meeting here, that the presentation will be available within 24 hours, if not sooner, on Drew's YouTube channel, our social media channels, and Drew's website. And yes, the PowerPoint presentation that Professor Barker showed throughout the presentation will be part of that. So the screen sharing that she provided will be there. All right, thanks so much, everybody.
Hi, Marianne. Thanks for being here.